were several brand new things in this poster session. First of all, different approaches to deliver nusinersen in patients who have been had a spinal fusion. So there was a poster about transforaminal injection, and also with a catheter to inject directly the nusinersen. There was also several posters about the follow-up of patients with nusinersen during the extended access program. So there was a poster from my team on the 14 months follow-up of these patients. There was a poster from Stanford team about the adult treatment in nusinersen. There was also several interesting posters about new methods to assess the patients, including the new technology. For instance, the Columbus team is delivering a very interesting outcome, like the walking space. So what is the walking space on this patient, and how the patients who are treated may improve their walking space. In type 1, the active mini, so the quantification of movement, and the team from Paris also bring interesting data on the new technology, like the connecting device that allows to point out a significant drop in SMA type 2 patients within a very short time. There was also a poster about newborn screening and the cost effectiveness of newborn screening in spinal muscular atrophy. So yes, there were several new things in this poster session, and I was happy to share it. I think this poster is highly relevant. There was 1 year ago a paper published in Neuromuscular Disorder about fractures in spinal muscular atrophy. Fractures is a common feature, and we see more and more fractures because we have patients who are not moving, who have very few movement, and with the treatment they are moving better and better. So it is good for the patient, but it also increases the risk of fractures. And so the vitamin D and the calcium hemostasis in this patient is very important to be followed up, and we still have to learn how to manage it. The risk of fracture is such in this patient that we have to learn how to follow this patient, and I found this poster extremely interesting because to follow the bone mass in this patient is something that we have to learn how to do, and should we do it on a 1 year basis, when to start, or when to treat, is something that has to be developed in the new standard of care. The standard method of delivery is intrathecal injection performed directly through a lumbar puncture. However, this is difficult in patients with severe scoliosis and in patients with spinal fusion. And so there were several posters, at least 3, about different methods of injection. There was a poster from the team of Garches in Paris using the CT scan. There was a poster using a catheter that goes into the spinal cord, which inject the treatment, so you don't have to perform the spinal fusion. It's what we do for other medication like baclofen for decades now. And there was the sus-occipital injections. All these approaches, of course, have even more burden than simple lumbar puncture. There is the irradiation, there is the cost, there is the risk. So I think that it's very interesting to see that something exists, that it's still possible to inject these patients, but it underlines the need of having medication with a more simple route of administration, and also to settle properly the expectation that we can have from a medication before starting the treatment.